So what we do with the Policy Roundtable, again, is try to pivot while leveraging our reflections on the evidence and the other benefits and the contextual issues. And boy, in every case, when we pivot to do that, there are broader issues around patient community and clinicians, payers, and manufacturers that we talk about. But I can't imagine any topic around which there's more beyond the evidence that we need to grapple with in terms of where we're going as a country, how we figure out how to optimize the access to treatments for a terrible, terrible condition that is still crippling so many communities. So I just want to welcome an extended policy roundtable, and I'll apologize in advance because in an hour, each of you will probably get 2 or 3 minutes to respond to a question. It'll feel that way. But we really appreciate your being here because the diversity of perspectives is very important to us. We've already introduced the clinical experts this morning, and I'd like to introduce the rest of the roundtable. Why don't we just have you introduce yourselves with your name, your organization, and also if you have any financial relationships, the manufacturers will be relatively clear, the financial relationships, but others, if you have any financial relationships with the industry, kind of either on the payer side or the manufacturer side that you feel should be disclosed. Maria?
Thank you. Maria Schiff. I'm with the Pew Charitable Trust, the foundation, and I am working in the area of substance use treatment and intervention after leading Pew's research specifically on healthcare delivered in jails and prisons over the last 3 years, and I don't have any financial interests that overlap here.
Hi, I'm Kim Lenz, Clinical Pharmacy Manager for Mass Health, the Massachusetts Medicaid program, and Associate Professor in Family Medicine and Community Health at the University of Massachusetts Medical School.
Good afternoon, Barbara Henry with Harvard Pilgrim Healthcare. I'm a clinical pharmacist responsible for all UM and drug coverage decisions.
Hi, I'm Rick Malamet. I'm Chief Medical Officer at Braeburn. I'm a neurologist by training with pre-industry work treating patients with pain.
I am Amy O'Sullivan. I'm a health economist. I lead the health economics and outcomes research team under medical affairs at Alkermes.
And I'm Ann Wheeler. I'm a doctor of pharmacy, board certified in psychiatric pharmacy with extensive expertise in severe mental illness as well as substance abuse disorder. I have 20 years experience working in managed care pharmacy, but I'm currently the head of behavioral health medical affairs within DeVere, as well as the head of managed care medical affairs, where I lead a team who's responsible for working with payers.
Super. Thank you again and welcome. And it really is hard to have this kind of discussion without a visible patient at the front table. We really work hard to have that happen, and we're very disappointed and sorry that it couldn't happen in that way. So we will all, as we would want to do anyways, to channel a lot of our discussion around policy and clinical work and think about the patients and the families that are so severely affected. And we will talk about pricing and coverage and all the kinds of hot-button issues. But I want to make sure we circle back and talk even more about the fact that the evidence and the votes seem to kind of be a bit of a statement that we have multiple options that are kind of in the same ballpark as far as an average effect as they can be viewed through the studies that exist so far. Let's nail as closely as we can some of the perspectives on how clinicians and others might identify patients for whom one of these options is distinctly better, offers a really different kind of level of benefit perhaps than other options. And we've already done a pretty good job at that. But let's think about injection again. Can you just identify what are the kind of stereotypical situations or types of patients for whom the injectable versions will be the right choice as a first option for MAT? What would you say to that? And I guess you can throw in Probuphine implants as well. So we're kind of thinking in distinction to Suboxone, where do we find the niches where the new treatments might offer a distinctive advantage?
As a general rule, I mean, extended release, or whatever you want to call these preparations, from a pharmacokinetic and a clinical pharmacology perspective, are vastly better from a compliance perspective, right? Even the oral ones, like oral calcium channel blockers that are extended release, are much better in terms of compliance than the ones that have to be taken several times a day. As I mentioned earlier, this is not usually a major problem with opioids, right, from a compliance perspective. People manage to remember to take their opioids. They're reminded when they go into withdrawal, but it's really not a big issue that we deal with. So I think from a compliance perspective, it's not going to be as major a benefit as it's going to be for all of the other medications. But I think the idea of maintaining a constant blood level and avoiding the peaks and troughs that you'll get with multiple times a day dosing is a substantial advantage. Both from a functionality perspective, where you're not sort of having highs and lows during the day, and also potentially from a misuse of other drugs perspective by not having those lows where you feel like you need to supplement. So I think from that sort of compliance perspective, even though it's not remembering to take your drug, it's not necessarily feeling compulsed to do something else in place of your medication.
So, since some of the trials, at least, or most of them, were head against Suboxone, and the outcomes on relapse, et cetera, were sometimes a little bit better, but done in a non-inferiority way, it's always kind of hard to do that consideration. But are you saying that in the real world, you think there are greater issues around the compliance or the adherence that would play out in certain types of patients, perhaps, or? Because it sounded like most of what you were saying could have been picked up in the trials as they were performed.
Yeah, but I guess I'm not sure I completely understand. Obviously, if you get an injection of a medication that lasts a long time, compliance is 100%. Right. So you're going to never be at 100% with anything else that you have to take 2 or even once a day. So compliance is going to be better. But I'm not saying compliance is necessarily the right answer. It's not even, compliance is sort of one part of it. I do think that just the kinetics of the drug with ups and downs and sort of the shifting blood levels that you'll get and the corresponding clinical effects of it are advantageous to having a steady state blood level. Even with the pain medication opioids, it's sort of the same idea that you're maintaining a steady blood level and you're not having the highs and lows during the day. I think the highs during the day are not that big a deal with buprenorphine. People don't get very high from it. Well, you can, but not usually this population. But the lows can be problematic because it's a dysphoric period. People feel as they do things they might not otherwise do. And even though they're not as low as you get if you shoot heroin several times a day, right, because it's a long-acting drug and it's a partial agonist, the depth of dependence is much less. I still think there are concerns about that. So I do see a benefit to using a longer-acting drug from that end of the compliance. So I guess that's really not the right word. I guess it's sort of the use of other substances end of it.
All right. Joe, what would you add to that, if anything?
Well, I think the fact that the injectables are not, hugely superior tells you that adherence is probably not the biggest challenge of buprenorphine's efficacy, to just kind of underline that point. I've been realizing I'm going to be filling out PAs for the people next to me. So I've been trying to think about, what are the prior authorizations I would send for these medications? I think there's a few places where I can imagine this happening a fair amount. In my population, the medication supplies are sometimes insecure, so they're getting their medications stolen or lost, or feeling like they have to sell them on a pretty regular basis. So for that population, certainly an injectable is, a very strong argument. I think there's another kind of more subtle part of the adherence question, which is people who are kind of ambivalent about it and would like the choice taken out of their hands. Now, I want to really distinguish this from people who are ambivalent about it and being forced into it. So one of the concerns that you would have with an injectable is that people will be sort of coerced in one way or another into a long-acting medication they don't actually really want to be on. And I just have concerns about that from a kind of patient autonomy, basic human rights kind of level. But there are some people who say, look, I'm really struggling with this. Different days are different. I know that the part of me that I most want to honor in this particular conversation with you is the part of me that does not want to use opioids. And I know that I skip doses when I do want to use opioids, so I want to do this. And there's usually some clinical evidence that that's happening, but the biggest clinical evidence is the patient's history. I think for that set of people, this could, the injectable buprenorphine in particular, I think could be, a really powerful option. And then, I think there are obviously institutional settings where I think people may find this to be superior, and corrections is the most obvious.
Yeah. So Maria, let me invite you in on that line, because you've thought a lot about the policies related to MAT and the correctional system. Is there a specific view about, again, a relative, not niche, but specific benefit to having injectable or implantable forms related to the passage of people through the correctional system?
Well, corrections always thinks about diversion and bartering, trading, selling, and there's also huge stigma in correctional officers in terms of treating individuals. So. And I should say that on the state prison side, in general, the 50 states have taken different positions on this, but most states don't offer anything at all, but the states that are in the forefront are willing to consider medication as somebody exits, not during the confinement or the sentence. So the injection is the logical choice, and many of them are doing pilots. For that, because presumably the person's been clean, and and as other people have mentioned, those first 2 weeks when they leave are quite a threat to mortality. What the DOCs are finding that have started this is that the attrition rate for shot number 2 and shot number 3 is really, really a problem. So continuity, is a problem, and whether the usefulness of doing injection number 1 and at least helping that mortality the first couple weeks, okay, but in terms of long term, there's a real ways to go.
Just one quick follow-up, and again, it may differ in so many ways given the circumstances, but I could imagine a prisoner being released, gets an injection and doesn't have to see a doctor for a month, versus one who gets 2 pills and has to see a doctor within 3 days. I can see it both ways. I can see it because it's a turbulent time of transition. Maybe it's better to give them longer before they have to see a clinician, or maybe that just gives them more ways to get kind of lost again, if you will, or to not follow up. Whereas if they have to follow up in a shorter term, it's better for adherence. Do you know if there's any data at all on that kind of?
And let's just differentiate between states where an individual leaves prison and is insured by Medicaid versus the states that didn't expand Medicaid and that person's going out with no insurance at all and therefore really doesn't see a physician or unless there's a free clinic or a transitions clinic, some such thing. Everything we've been told is that, for sure the first thing on somebody's mind the first few days is not keeping an appointment at a community health center. So to the degree...
But Joe's a great guy. He's there for you. Right?
So to the degree that it buys them some time. But again, the data in this area is very, very new, and the data systems often don't follow somebody once they walk out the gate. They're lost to the data systems of Medicaid and other kinds of things. So there's a long way to go in finding out what works for this population.
What percent of prisoners in the United States who have a history of opioid use disorder leave prison without any form of medication-assisted therapy provided for them? Any idea?
Large. I can't give you
Still,
whole swaths of the United States, not to mention the Federal Bureau of Prisons, which only has one pilot going on. And again, I'm just talking about the prisons, not the jails, which is really, the jails have circulation far in excess of the state prisons. And where people are most acutely by the time somebody gets to a prison, he or she has been forced to withdraw.
Right.
So the issue in state prisons is really on release. Jails is on entrance. Those are two different things.
Okay. And if you could do one policy maneuver with the flip of a switch, would it be to ensure Medicaid coverage for every prisoner at discharge across the country? Would it be something else? What would it look like?
For this population?
For this population.
I definitely think that's necessary but not sufficient.
Okay.
And I think that would get a big bang for the buck. And there does seem to be a correlation between the states that didn't expand Medicaid, at least until this past Tuesday. There'll be some changes, but that didn't expand Medicaid, and those that have the largest incarcerated populations in the country.
Okay. We'll come back to, it's not our last word about the correctional system, but thanks. I wanted to bring up an aspect of the value that sometimes, and I know that, I forget which ones of the manufacturers mentioned it specifically, but the issue of diversion, impact on bringing it up or down. Can you restate again how you think injectable or implantable versions create a net benefit because of its impact on diversion?
Yeah, I mean, there's an inherent benefit for one. And let me just, before to go back to a point that was made, you know, we're looking at data in a clinical study, clinical trial, which is not the same as real world. So I think we all should be clear on that. So when we're measuring outcomes within a clinical study, compliance is usually a bit better because they're being followed, they're called, they, for whatever reason, come back. So I think we do need those longer-term studies. Now, back to your question, you know, we know that buprenorphine is frequently diverted. You know, we have data that 60% of patients have used, 57% have used diverted buprenorphine. We also know that buprenorphine compliance is not good. I'm talking about the sublingual, in which we know that only 37% are still on it 30 days and only 72% are on it 6 months. That's not good enough. So I think from that alone, to get patients on their medicine and have them stay on their medicine is going to provide health benefits not only for those, but in terms of long-term costs. Now, in terms of diversion in general, and this is stating the obvious, if I give someone a pill, and this goes for opioid analgesics as well, you know, they can take the pill, they can put the sublingual, you know, in their mouth, or they may not, and you, the physician, don't necessarily get to control that. There's a financial incentive for these patients to sell out on the street. And then I think the point that was made by Reiner about the potential good benefits of diversion, and that perhaps you're sharing it with a friend who also needs MAT but can't get it. I mean, the argument there could be that we know that we need a certain percentage of compliance to get any benefit. So perhaps instead of one patient getting adequate treatment and doing well, you know, have two patients getting inadequate treatment and neither is doing well. So when you have an injection, it's administered by the physician, first of all, or healthcare personnel, or maybe in the future pharmacists. But we're not giving it to the patient. We're not giving the patient the injection and say, here, take this home and use it every week or every month. So you have an inherent control of diversion from a patient point of view. Still doesn't mean there couldn't be diversion from a physician or healthcare provider point of view. We know that in hospital anesthesia departments, ketamine is diverted frequently, and I don't need to go into that. So you're not totally solving diversion, but you are solving the patient diversion issue, which is huge. Not only are the patients not getting what you think they're getting, and that opens up danger later when you're prescribing other things. If they're not taking what you think they're taking and you prescribe something else, that's dangerous. But they're not getting adequate treatment because they're selling it or sharing it or giving it away. So an injectable inherently blocks that because it's there. That's an obvious.
So just one thing, and again, it's partly just because the word diversion has this connotation that comes from diversion of the opioids. And so people think of diversion as a really bad thing because it creates new addicted patients potentially. You could say it's just feeding otherwise addicted patients. But diversion here, as you said, you could have two inadequately treated patients and you're getting no benefit out of a single prescription versus making sure that at least one of the two is there. But diversion isn't, in a sense, diverting it to feed an opioid addiction. It would only be diverted to help other people try to treat the symptoms of opioid addiction.
Yeah, I don't know that we know that.
Correct. Well, let me ask how it's viewed from the clinicians.
So I work in this very active street market in Suboxone, so I can talk to the economics of this a little bit. I think that it is often used to treat withdrawal or periods in between opioid use and I don't know that it would be fair to call that treatment of opioid use disorder.
Good point.
I think you could, in a sense, I think people have made the argument for a sort of public health benefit of occupying as many of the mu receptors in the community as possible with a tight binding partial agonist. It happens, that the bigger consideration for me is that the DEA regulates my prescribing capability. Until recently, Jeff Sessions was, I just needed to imagine Jeff Sessions contemplating that policy proposition and sort of see it as a non-starter. So, so diversion is a serious concern because society has made it a serious concern. It is, worth noting that in our neighborhood, partly because there's probably a good 1,600 people, within about a block who are getting Suboxone treatment, the street price of Suboxone is approximately equal to what you described as the generic unit price. So if there is some public health benefit to it being out in the world, that would be reduced by injection, and you're having more medical and legal control over users' use of their buprenorphine.
Right.
And I would just, without having any idea of how that's going to play out, I would say I wouldn't anticipate that to entirely be positive results. But it's really hard to know what's positive and negative about that, and yeah.
Okay. Let me just let the other clinical expert chime in, please. Yeah.
I fully support that, but I do still stress that it's a harm reduction effort, because I think if you're in withdrawal from whatever opioid you're using and you have a choice between crime, illicit substances, or buprenorphine, you're still better off having buprenorphine. And yes, it may not be free, and it may not be what you'd like to see if you really wanted to have a harm reduction model. It's still much more available. Now, in a perfect world, you're right. I mean, I wouldn't want anything I prescribe to be going to anything other than it's supposed to be going to. But the fact that 30% or less of people who start on a buprenorphine program are still on it a few months later is very predictable for all of the addiction models. I mean, we know that it's a recurring disease. Nobody's ever cured. Everybody's in recovery. And I would say, with all due respect, that if you get your first monthly injection and you don't want to get your second monthly injection, you're still at the same point at the end of that month, having no treatment. So the same group of people that stop their buprenorphine sublingual will stop their buprenorphine injections unless it's a court mandated or some other. The people with the best recovery records by far are physicians, because of physician health programs, and nurses when they have those in the state. And anybody else with an occupational requirement to not be using substances. So without that, the recrudescence rate for substance use and the fall off is huge. I mean, a 30% rate of sustainability is tremendously high for the most part for most substance use programs.
Okay.
Can I just real quick, before we leave diversion, I know you're moving quick.
I'm going to divert you soon, but go ahead.
I know I'm going to be diverted. But we're talking what it sounds like about intentional diversion, about sharing, about giving, about selling. And that's part of diversion. Unintentional diversion is an equally big problem. We haven't touched on that. That's where the pediatric problem comes in. Abusers with kids may not want these pills hanging around. And again, unintentional diversion not only of children, but also from medicine cabinets for those who have them. That's one of the biggest sources of opioid analgesics, from the local medicine cabinet, where kids come in, they're in the house, they go up to the cabinet, they take. So I think it's not just intentional diversion we have to think about.
Well, I will divert.
If you don't mind. Go ahead. I mean, I work at a poison center, and this is a big part of what we do. Remember, we existed from the 1950s on to treat those sorts of pediatric exposures. And again, with all due respect, that's something that industry tried to put forth to the FDA and to others about why we needed to have strips of sublingual buprenorphine and not tablets, because the fear was that these tablets were all falling into the mouths of little children. By far, I'd rather have my kids, who are adults, but when they were little, I'd rather have them overdosing, so to speak, on buprenorphine than on any full agonist opioid you could possibly put out there. So if there's going to be some opioid in your medicine cabinet and my teenage kids want to get into it, I'd rather it be buprenorphine. The abuse of buprenorphine is very real, and people get high, but you don't get high for long from it, because once you develop any sort of opioid dependence at all, buprenorphine becomes a functional antagonist, and you withdraw as soon as you take it. So I really don't buy the safety for children issue. There are literally no cases of children who could walk, who were big enough to walk. There are some examples of children given buprenorphine, infants who've gotten sick, but these are tiny little infants who are very different than toddlers or larger, and I don't really think that that's a valid concern.
So let me move on then to the question, I think it came up from a perspective, rural patients, other populations. Is there something about having an injectable form of this that increases our ability to meet the need, to get to more patients? Or, and I know, Joe, you've had some problems getting the injectable to be used, for some homeless patients. But so talk a little bit about whether it creates a different structure to access in any way, potentially, or whether you've already seen it. Is it somehow help? Could it be linked to some other approach to increase the number of patients that doctors can care for? Is it easier to administer so you can see more patients per hour? Anything else around the way that this might or might not affect our ability to treat a broader population of patients who need treatment?
I think any of those are reasonable propositions. Like any of the things you bring up are reasonable. I don't know exactly how to put that to the test. And some of them I found that clinic workflow issues, excuse the clicking, I made the mistake of putting one of those candies in my mouth. Workflow issues are really hard to predict in advance. So you think, the injections are going to be quicker, and then it turns out that the nurse has to go here, and then they have to go there, and it turns out to take 15 minutes instead of the 10 minutes. I just think it's really hard to predict. I think it's completely plausible that you could come up with more efficient systems in a clinic around injections. I think it is plausible that it would expand access. I think it would probably, assuming that it did make the workflow issues easier, then you could have more centers having fewer visits. But that's also true of just giving somebody a big bottle of a bunch of buprenorphine.
Okay.
So there's not an inherent. The problem in rural areas is really the access to the prescriber, and less the access to the medicine itself, I think. I mean, you can get a pharmacy to order it, hopefully, with some exceptions.
Well, is there some linkage then between would having an injectable form make the DEA or other authorities feel like we can now let more nurse practitioners or others use this without the same kind of oversight, or are these different issues?
No, it's a great question, and I would side strongly with industry, I think, about the idea that this drug probably doesn't need to have a prescriber have a DATA 2000 waiver, for example, right? Because the risks of all the things we've talked about are dramatically less. I think the REMS program, and I was very involved with the REMS programs at FDA when they were looking at opioids, and I think the REMS program we put in place is a bit stifling, honestly, for people to access. I think the prior authorizations for all of these medications is a regulatory burden that a lot of people have to deal with. Not to mention the costs. I mean, so all of these things together make these drugs much more of a bureaucratic hurdle to get over than it would be if we were just able to freely prescribe this. Given the safety of these medications compared to the regular full opioid agonist, it always amazed me that that you need an 8-hour training course to give buprenorphine. You don't need anything to prescribe OxyContin, for example, right? And it just seems backwards to the way the world should work.
Note that down. That's a good quote. So, good. All right. I think it's time for us to start to talk about coverage and cost. If you remember that one of those first slides I put up where I say, there's innovation which meets a need, it's really important, and sometimes innovation raises questions about appropriateness and which patients and cost and all that kind of thing. And there was a good quote earlier from Maria Sullivan, your sister in arms, if not real sister, not O'Sullivan, but Sullivan. She said, we have a responsibility, I think she was talking about all of us, to do everything we can to improve access to these treatments. So my hypothetical is, if these treatments weren't priced 4 to 5 times as much as generic buprenorphine, we probably wouldn't be having this meeting. Because the purpose of our meeting on MAT 4 years ago was to get buprenorphine and methadone more accepted, figured out how we could deliver it, hub and spoke approaches, all the kind of trying to figure out how to expand access. But we're at a different point now where we've got that, and now we're getting additional versions of these treatments that really do raise significant differentials in cost as well as other questions about benefits. So how do you feel like your companies have exercised their part of that responsibility for improving access by coming out at prices 5 times above the price of oral buprenorphine? How could your companies take a piece of that responsibility and show commitment to helping improve access?
So, Steve, I would argue that the report that you guys did previously, which came out and really emphasized access for all these medications, unfortunately and tragically, we are in the same place. So, what's not covered in the report, I think, really robustly is the cost of not treating with any medication. 90% of the millions of people who have opioid use disorder do not receive any medication. So when we talk about the price of the medications, we have to consider the price of not giving them. And so I think the value in the extended release formulations, we have to consider the cost of not giving the treatments. We have to consider the cost of patients who don't do well on oral formulations, who fail on oral formulations, who divert oral formulations, and these, I think, all have to be part of that conversation.
So I know, you all didn't come in pricing your drugs at $10,000 a month, but they're over $1,000 a month. So how did that reflect, again, a responsibility and an exercise of your view of how to improve access to these drugs? Because you know that the real decision is going to be how to put them into context with Suboxone, and the differential in price creates, or that much of a differential in price creates a huge tension in the system where they will have to think, for every patient who could have been on oral Suboxone who goes on to one of these new treatments, I have $1,000 less per month to spend on other addiction services or other health care, or to keep the cost of care down entirely. So I'm just wondering how, if it's a joint responsibility, and we're coming to coverage, don't worry, if it's a joint responsibility, I'm concerned that I'm not sure how the companies are explicitly making the price and their justification for it a part of their commitment to that same responsibility. Maybe I'll just let that sit for a second. We'll come back.
So, I'll just speak for Alkermes. We take price and responsibility for that very seriously. We work diligently to look at all the aspects. It's a very unique and quite complicated, actually, manufacturing process to get the drugs into long-acting formulations. There's product quality standards, and again, these patients most likely have failed on an cheaper oral therapy, so that product didn't work for them. So the value, although the cost is quite a bit cheaper, the value is zero to that patient.
So we've seen some companies recently, actually, probably most notably with the high cholesterol drugs, have actually trouble getting the kinds of uptake and the access to it that they and clinicians and others would want. And they were willing to lower their price to a value-based level in association with an external judgment of cost effectiveness in return for a reciprocal engagement with payers to make sure that the access is really streamlined and would meet everybody's goals for making sure that the patients who can benefit most can reach that. Do you think your companies would be interested in an arrangement in which payers would come together to offer that kind of reciprocal arrangement if you were willing to have the price align with somebody else's, I guess, judgment of what your added benefit to the clinical value is. Is that something your companies would ever be willing to explore, you think?
Yeah, again, I'll speak for Alkermes. I mean, the first thing I'll say is that we have quite broad coverage. So we're covered by all 50 Medicaid states. We're covered by most commercial plans. So I'll just start with that. The second thing I'll say is we are absolutely open to engaging in these types of conversations, and we have been engaging in these conversations, and we have put some of these in place.
Right. Richard.
And again, we're, as has been said, we're at a point where we're awaiting approval. We're negotiating now.
Right.
We don't have a price.
But
it's a
offers right here on the table.
I'm going to divert you. So
I have a price for you.
No, but I think it's a. I've read something in the news about drug pricing. I don't know.
Every once in a while, yeah.
I've heard something about it. But I don't want to leave the point that Amy made is that for most medications, and I think this is no exception, patients will right now have failed their sublingual bube, their oral bube, for various reasons. I mean, we had a great discussion a few minutes ago about what patients are appropriate to go directly to extended release, and we could talk more about that. But I think, to your point again, I don't want to speak for you, is that it goes beyond price of the drug. It goes beyond cost savings downstream. And with this disease, it's not an inconvenience. It's actually a high mortality disease. So we're not just talking about saving downstream money. We're actually talking about saving lives. So I don't want that to be lost in the conversation. I know you don't, but I just...
No, absolutely, and I'm glad you mentioned it. And going back to our original report, it's one that I like to hold up because we did find that it saved lives and saved money in the health system, even before you go to look at the societal impact, which is even broader. And I forget the exact numbers, but for every dollar invested in the pill, you gain something like $3 back in the health system itself, even in the short term. So that's a critical issue. Now, it's interesting, you both raised the point that most, or I think you said most patients who would start these would have failed Suboxone. So a payer hears that and thinks that and wonders maybe that's the way that coverage should work. Right? Because that's what you said, that's where the value is. The real value isn't for patients who can't or don't succeed with Suboxone. There's an absolute need for other options for those patients. Yeah. So let me just pivot to the payers, and I'll come back, don't worry. Okay. But I wonder, because now you can answer that, but as far as stepping back, let me also tee one up for you guys. There are certain conditions, life-threatening or otherwise, for which you really want to provide every single option available to make sure that the access can be as broadly successful as possible. And you feel both a social kind of imperative to do that. You probably feel a business imperative to do it, a legal imperative. And that may mean that you feel like you can't walk away from the table when you're negotiating prices. You can't say, sorry, that's just too high a price. We're not going to accept this. We want it, you want it to be available. Or not. How is it feeling to you, as payers, think about how you craft the access to these newer options for MAT? Barbara?
So, very interesting question, Steve. So I think that prior to the newer, longer-acting agents, and I can take Vivitrol aside because at that time it was the only one, somewhat unique, different population. When we were only dealing with the sublingual buprenorphine products, we did turn our back on a lot of the traditional cost savings and utilization management strategies for the greater good, perhaps at a financial risk, and I challenge some of you to take that on as well. So we really tried to increase access, decrease cost share, make these available to as many people as possible when the sublinguals were out there. We are now, as everyone knows, Harvard Pilgrim bangs the pay-for-value drum pretty loudly, and these products are making it hard for us to continue that feeling of increasing access, ensuring adequate access, and decreasing cost share. So we would like to be able to turn our back on some of the traditional cost savings initiatives, but I just don't see that the value is there. And so with that, I think every stakeholder has the responsibility to increasing access and decreasing cost barriers, and it's not just the health plans that are responsible for that.
Kim, and remind people they know, but so Barbara's with a private insurer, Harvard Pilgrim, and Kim is with Mass Health.
Yes, thank you. So I should also caveat that policy is representative of Mass Health, but soapboxes that I may jump on are my own only. So yeah, I mean, in the Medicaid program, we have a little bit of a different thing happening because we can't make something just excluded from our formulary. The way we work is that if the manufacturer participates in the federal rebate program, we have to cover the drug. And so our lever there is putting things in front or creating PA criteria, but we don't have an option of not covering something. But we have a great administration. Everybody is focused on providing access to these medications, trying to bend the curve that we're seeing with the epidemic. And we have access to Vivitrol, and we have a preferred buprenorphine product, and that comes after our administration worked with manufacturers in a competitive procurement to drive the lowest net cost of a buprenorphine product. So, you know, we do have Sublocade on prior authorization, and we are looking for rationale as to why you can't use our preferred buprenorphine product. So, you know, to the point of all harm reduction, it's not that we're not treating somebody, we're just saying, can you use the preferred product? And if not, why? And I think Dr. Wright brought up some really good points about access, and we take all of those populations into consideration, which I know you've looked at our prior authorization criteria, and if anybody else, especially Dr. Wright, has, we leave it very broad to say, like, please tell us what you think is so compelling about this member that we should be going outside of our preferred products.
All right. Let me follow up. Oh, go ahead, Joe.
Well, just as you know, we're clearly frequently, you know, most of our patients are Mass Health patients. We have a tiny percentage of private payers. So I think the other thing the context I want to add to the discussion of price is that Mass Health and most other Medicaid programs are in an ACO model. Mm-hmm. And so the ACOs within Mass Health are responsible for keeping prices at a fixed level. So you know, I'm, as an individual clinician, going to advocate for my patients. Obviously, I have the responsibility for stewardship, but I'm going to try to find the best option for my patient. But I am aware that my pediatrician friend at the community health center down the way is either going to have the money or not going to have the money for asthma community health workers who aren't directly reimbursed on a fee-for-service basis. And that's the kind of thing that happens when drug prices go up. I am so grateful to Mass Health for making Hep C drugs available in a really great and public health oriented way. I literally went up to Dan Tsai with tears in my eyes about it. But it you know, it had a huge impact on the program. And so this is not a trivial public health question, not just in the level of opioid use disorder specifically, but if we do expand treatment, which is what everyone says we want, then does that destroy other kind of health outcomes? And that's, in an ACO environment, that is not a trivial or theoretical or sort of academic exercise.
Yeah, I think it is useful from a policy perspective to remember that the way that even Medicaid is delivered, it can be delegated financial responsibility. So it's not just the health plans or Medicaid that's trying to watch over a budget. It can be, you know, the whole system in a way. So that's where, again, some of this tension ends up playing out. So I am going to actually walk through pieces of the UMass prior auth form and just ask some questions about how it relates to some of the evidence and some of the options. And we'll get to some very important issues that have kind of been alluded to. So one thing I just will note, and this came up in our report from 4 years ago, there's a real desire on the part of Mass Health to make sure that patients have access to counseling of some kind. They don't set it up as please send me documentation that the patient has been to a counselor or has an appointment with one. It's just, do you as a provider have access to a counselor that this patient can see? If not, Mass Health will arrange for one. Is that proving to be a barrier in any way? Because we heard 4 years ago that in some ways the requirement for counseling was being either administered, I guess, as a way that was a hang-up in the prior auth phase of this. And people said, just give them the Suboxone. Don't sweat whether they've got an appointment with a psychiatrist that's impossible to get anyway. So how
Can I
do
just
people...
clarify the policy just so it's not misinterpreted?
Yes, please.
So by no means is it a requirement to
Right.
access to the drug.
Right.
It's simply that if you don't have it, we'll make sure that it's offered to you, but it has no bearing on approval of a medication.
Right. So I was going to ask, just outside of that example, and maybe it's the manufacturers who would know more about this, are you hearing that in payers across the country, is this an issue around access that's proving to be a significant barrier in some cases still, or has it been addressed in the way that Kim does, which is not to make it any kind of requirement to get a prescription?
I think it's been well addressed, and I'll give my opinion not only as a representative of Indivior, but just from a historical perspective, having worked for a large national health plan, that this is something that, we, with our criteria, we had to just make it very simple as it is with Mass Health, because there are mental health parity laws that would prevent you from requiring any sort of proof, because you wouldn't necessarily do that with a chronic medical condition. So to treat them in the same light is very important. So I don't see that particular requirement for psychosocial intervention is impacting access.
Okay.
I would say that piece of it makes the value-based discussion that much more difficult, though, if you go back to the talk about value-based agreements, because definitely that's something that I think across the board people are open to those types of discussions. However, with those added necessities for that psychosocial component, that makes it much more difficult to evaluate the benefit of the medication versus the benefit of the psychosocial treatment, and what can we do to ensure that people are getting access to those types of important treatments.
Do you guys still basically feel that, and I forget how your protocols are run in your trials, I apologize, is counseling, should it be the default?
The default or the enhancement too?
Well, we're not using it as a requirement to get the prescription filled, but should the system try to advocate for patients who are receiving MAT to be concurrently involved in some kind of counseling?
Yes.
Yeah.
Yes.
Yeah.
Okay.
And again, while in our control trial, the one that was referenced here,
Yeah.
we didn't have that because it's an active treatment that could confound results. However, in our 12-month open label study that wasn't referenced here, patients were encouraged or allowed, however you read it, to have adjuvant psychosocial counseling, and in fact, more than half did, in addition to their open label CAM 2038.
Okay, great. Okay, so moving on through the prior auth, and this is meant to cover a bunch of different situations. So one says if you're going to be exceeding 24 milligrams a day, just kind of tell us why, what's going on. Another is if you need to prescribe buprenorphine and an opioid, kind of what's going on. I think there's reason for people to be somewhat concerned that that's being handled appropriately. So getting down to things like Probufene and Sublocade, what's the right way? I mean, what are the options for, not the right way because that's too kind of prescriptive, but payers could approach this by either having no prior auth at all, or by asking a clinician to say, why is it medically needed, or by having very specific criteria that you have to tick the box or document. What has been your experience in thinking through how to exercise those different options and the pros and cons maybe of different approaches, from no prior auth to, I guess you'd call it attestation, but in some way the clinician has to do it. And Joe, you may have experience of writing in a blank field why the patient needs it, to a more precise set of specific criteria. So pros and cons of some of those.
So I can speak generally here. One of the challenges in this space is, do you really want to encourage a failure of the sublingual first? That doesn't really seem ethical in some cases, so that's a challenge. But even more so than that, I think the biggest challenge is, and we've talked about it on several different occasions, we're not really sure who the appropriate patient is for these long-acting agents. So I think that's the biggest challenge, and I think that's where there needs to just be a partnership and some type of, going on faith as to what the provider thinks is appropriate as to why.
What do you think?
Yeah, and I think we share the same concerns. I mean, we're trying to figure out who the appropriate population is for Sublocade in particular right now. As mentioned in the previous conversations, I think we don't really see a very big population looking for Probufene because of the dose limit. So focusing my attention on Sublocade here, I think we're, again, looking for why you can't use a preferred product because of the net cost to the Commonwealth. But outside of that, we're trying to take into consideration populations where controlled substances may not be appropriate. Like if they're in a release house where they're not allowed to have controlled substances, is that appropriate? Populations with unstable housing where there's diversion in the house. We're taking those patients into consideration, but I think because of the significant difference in cost, the lack of evidence showing clear superiority of the product over the films, we are really, as a state, and the fiduciary responsibility is to take it very seriously about what patients are appropriate, and that comes down to a conversation that our clinical team has with prescribers, if it's not clear on the form.
Yeah, okay. So perhaps the most specific question that you alluded to was the step therapy idea. So it's not here, and I'm not suggesting that anybody is thinking of instituting it, but I'd be surprised if there weren't some payer, some PBM, some group somewhere in the country that's looking at the data and looking at the costs and saying the best way for us to get a lower cost is to kind of sustain this in different ways might be to have patients, unless there's some given reason at the beginning at least, to try Suboxone first, which would then, if that doesn't work, again, with a different approach to attestation or some other kind of documentation, then open up coverage to an injectable version of it. You coming in as a second injectable will probably be offered different kinds of approaches with payers as a company in which that might be something that's considered. How do we all think about that? How do we all think about that?
I mean, again, I'm going to be data-driven because that's what I do, with apologies. But, I mean, we already know, and while sublingual buprenorphine may, in fact, be quite effective, and it is, I believe, if we know that a third of patients are already off by a month and 2/3 are off by 6 months, it doesn't matter if it's effective if they're not taking it. And we know the impact of not taking MAT at all. It's relapse, it's extra cost, and it's death, overdose and death. So when I look at retention, I think that's the kind of data that we need. And beyond the 6 months that we've all done our pivotal studies for the FDA, and again, just to share 12-month data, open label.
Well, Richard, let me just cut in.
But still, 12-month data were 80%. 80% at 12 months stayed on chem. That's important.
So almost like in a court of law, I will, what's the verb, grant you that point. Let's assume that retention or relapse is lower on an injectable form. Adherence is better, et cetera. That doesn't mean that a certain proportion of patients aren't okay with long-term Suboxone. So, and it doesn't mean that every patient who starts on an injectable doesn't end up using illicit drugs. So the potential logic of doing a step therapy with a Suboxone still is on the table in my mind. I'm granting that an injectable, if you had to flip a coin, which one's more likely to have an adherent person in 6 months, I'll grant you that it might be the injectable, or is based on the data that are there so far.
I'm going to agree with your point.
So
I think there are going to be patients who are going to do great
Yes.
on sublingual buprenorphine. You don't know who they are.
Right.
And if you're wrong, there's inherent difficulties.
Right.
Likewise, I grant
Right.
as well that not everyone on the injectables is going to still be
Right.
on at 6 or 12.
So if a payer came to you, if this completely hypothetical payer came to you and said, I want to make every single drug available, and I want to make it available even without having to go through a step therapy approach, I'm going to need a price that makes sense for that. How does that conversation work? Does that work for you? I mean, in terms of the quid pro quo, the mutual exercise of responsibility, I get a sense that the payers are hoping, that they're thinking about doing different kinds of prior auth and other approaches now that there are multiple options at very different price points. And there's a tension there, and I wonder if part of that tension can be solved by a lower price that would meet with improved access. The win-win that I think we're all after. I know you're not going to. I know. Don't worry. You're not. You're not here. But I'm a full-on Pied Piper for that kind of thinking, in which I think there really is a common goal here. The question is, can we get there? Because the goal is to expand access to make all these options available, to learn better from clinicians and researchers how to make sure we know which patients will benefit more, perhaps from different, versions as we learn more about the real-world evidence. But we've all seen this too many times. If the pricing and the budgetary issues create too much tension, we might not get to that point for a variety of reasons. And the patient community and Chief Ryan and others are not going to be happy if he's still here. Amy?
Yeah, I just wanted to make the point that this has been, I think, summarized throughout the day, but Vivitrol is a very different option. So I think, mandating sublingual Suboxone doesn't make sense there. Vivitrol is the only medication that's indicated for prevention of relapse following opioid detoxification. So for patients who have been detoxed from opioids, for patients who do not desire to go on maintenance opioid agonist or partial agonist therapy, or for patients who have failed maintenance opioid partial agonist therapy, Vivitrol is the only option. And SAMHSA and the Surgeon General have said that patients who have been detoxified from opioids should be offered Vivitrol to prevent relapse because those patients are at excessive risk of relapse.
I hope you don't mind my raising a somewhat probably tender point, but it's been in the press. Alkermes has been accused of creating a sense or spreading a sense of stigma among clinicians who around the idea of treating with buprenorphine-based treatments when Vivitrol is the anti-buprenorphine option, if you will, a contrasting approach. Since stigma has been such an important issue for this community and for everybody, and we're all trying to make sure we reduce it. And I don't know if, again, I could ask the clinical experts if they've heard of this but it's been in the news, and I'm sure you've heard about this issue. I think there was even a lawsuit. But is there a way that we can make sure that your statement is heard in its fullness, which is it is a different approach, it's for a different patient population in a way, while we have to make sure that the availability and the stigma associated with other treatment options is not a problem? I'm not sure I'm really asking a question, but
yeah, I mean, I don't.
Reaction?
Yeah, I mean, I'm here to advocate for access for all treatments. I think patients are extremely heterogeneous in this disease space. They have different patient preferences, they have different goals, and they're going to have different success rates with different treatments. So with respect to stigma, I think, I hope we spend more time on talking about education, awareness, and access to all of the medications, because as it has been said throughout the day, different patients will respond differently to different options. And it's very important that they are well educated on all the options and they have the ability to work with their physician to choose the one that's best for them and their recovery.
Okay. Joe?
I'm hoping to also talk specifically about corrections.
Please.
In relation to price, and then in relation to the question of stigma. I think on the question of price, you can look at hepatitis C as an example of an incredible public health opportunity for corrections, a place where corrections could make a huge difference in the public health of the nation. And there's all kinds of evidence to show that. The pricing of the drugs means that we are not taking advantage of that opportunity. I think there are selected corrections systems that are giving people medication on release. There is a significant argument, especially in jails, to just give medicine throughout. again, you're dealing with the limited budget problem and the problem of kind of the stigma of treatment. So unlike Hep C, where it's strictly financial, there's sort of two reasons that corrections officials may be hesitant to really step into the treatment of opioid use disorder and to use anything. I think they have favored Vivitrol for the reasons that you talked about. But I think, I guess just returning to that question of price and kind of the public health, I really hope that the manufacturers in particular will think about distinct conversations with correction systems in particular, which is what I wish the Hep C manufacturers were doing in more earnest.
When we looked at it, I think it was between 30 to 35% of the national prison population was Hep C positive. So I know that opioid addiction is that high, if not higher, I would guess. Maria.
So those conditions often are housed in the same person, obviously. Our observation is that the Departments of Corrections have moved along with treating hepatitis C largely as a result of targeted lawsuits, and that is actually our observation of how correctional health lurches along. The Medicaid agencies sort of lead the way. I mean, it's a very, very interesting differential. As Kim said, the Medicaid agencies are under a federal law of getting best price, and in exchange for that, have to cover every medication. The Departments of Corrections and jails are not eligible for that best price. And the other differentiation is that Medicaid agencies are reimbursed by the federal government at least 50%, whereas the county jails and the state prisons are 100% county money and jail money respectively. And the name of the game, offsetting the captive audience, as you pointed out on the Hep C, is that the day the person walks out of the state prison, the treatment for Hep C is then, at least 50% borne by the federal government. So the counties and states are making these decisions, looking at how long the person's sentence is, when will he be out, and is it an expansion state so the person's going into Medicaid? These are very conscious on some people's parts.
Right.
The other issue is that Medicaid's been doing this for a long time, negotiating, and the Departments of Corrections are very new to the game of understanding that they are a player in the pharmaceutical world, and they don't have nearly the bench strength that Medicaid agencies have in terms of navigating with pharma.
Right.
It was just striking as somebody who had come from the Medicaid world and the naivete or lack of experience on the DOC parts.
All right, thank you, that's very helpful. So with the time left, I know we could keep going, this has been great. One of the things we like to do towards the end is to let each of you have a closing statement. And I'd invite you to think of either something that you just think stands out to you as a critical message that you want this audience and the report to take away. I often invite people to think of a request. So if you had one request to make of some stakeholder, what would it be? With a common goal in mind of making sure that we get sustainable access to high-value care for all patients, what do we need to change the landscape or to do something with the evidence as we translate it into policy that would get us there? So your thought, and I usually try to also ask you to do it in one sentence with one semicolon.
How many conjunctions?
Today, I don't think my children know what that is. I say it's a long comma, all right? So you can do a long comma, but why don't we start, Joe, why don't we start down with you? So key takeaway and or a request for something from somebody that you think is really important.
I think I managed to weasel it in my last statement, actually, which is I think the most targeted thing I would say about the highest risk population is focusing on how these products can be used in corrections and how that is actually going to happen as opposed to theoretically going to happen.
All right, thank you. Maria.
I would urge policymakers, and that includes legislators, to understand that for populations under the age of 65, the state is sort of a self-contained health ecosystem, and that for a DOC to make a move with not being in concert with the jails in the state is throwing money away, and to bring in the state Medicaid agency as well for a holistic conversation about this cohort of population that goes through these systems.
Thank you very much. Okay, Kim.
I think my one wish would be piggybacking off of what you said about seeing if we could work with manufacturers to get prices to become at a reasonable level with qualities that match the value so that all insurers, not Medicaid, but everybody can afford to open access to all of these drugs. And my long comma would be also what Maria said about I think we need to find a way to be treating patients while they're incarcerated in the jails because I think personally it's inhumane to not do that.
Thanks, Kim. Appreciate it. Barbara.
So Kim stated my position very eloquently and probably better than I could have. But I would have to just say, I think this is a public health crisis, and we all need to stop having silos and be more collaborative. And I think at the crux of that is value-based pricing and making this at a price that we can afford to treat everyone.
Thank you. Richard?
Yeah, I would just reiterate that both physicians and patients need options. They're not identical. They're going to respond in different ways. Semicolon, we need to be evidence-based in doing that. We need to look at the data. We need to look at all studies, not just some of the studies. So I would urge everyone here in the room to read all of the clinical studies, whatever they are, and I think make a decision based on the data.
Great, thank you. Amy?
Yeah, just to echo some of the points, we're in an unprecedented public health crisis. The death rates are rising. Our life expectancy is falling because of deaths from drug overdoses. We have 3 different types of medication that are FDA approved for treating this condition that are drastically underutilized. And so I would just ask for continued education, awareness, and access to all these medications.
All right, thank you. Yeah.
And I'll just add on to that and just say that it's been said that patients don't fail treatment, treatments fail patients. And so I think that we need to keep that in mind and that every individual's journey to recovery is different. So it's important that we have access to these different treatment alternatives that are available and that we as manufacturers continue to invest in the real-world evidence that's necessary to demonstrate the value of these products, which Indivior wholeheartedly is investing in. And we are very interested in working with our payer partners as well as with corrections to taking this to the next level. And so that was my long comma and semicolon.
We have a judge.
I thought, anyway, go ahead.
I would just urge payers to recognize that reports like this are just one piece of the evidence puzzle, and we will continue to work to supply the evidence necessary to make a good treatment and coverage decision.
All right, thank you. So I almost feel like what each of you said at the end could have been an entire day's symposium or seminar. So I really appreciate your coming to engage in, an hour is just really not enough time to do justice to some of the issues. But I also think you did a fantastic job of highlighting some of the key goals, some of the key tensions that we all are trying to address as we move forward on this. So I would just invite the audience and the CEPAC to thank our Policy Roundtable from today. Now, but your service is not done. No, if you have to go, you have to go. But what we'd like to do is I'd hand it back over to the chair, but in doing so, what we do at the close is to let the CEPAC members themselves have a final closing statement with that same long comma or semicolon, or not and. But it's, and that way we'll be able to be done by 4 o'clock so everybody can go. And this time I'll start on this side so that we end up with the chair. Okay. So Stephanie.
Great, thank you. Thank you to everyone, all the thoughts today. There was really thought-provoking and certainly will be things that I'll be taking home with me on my ride. Specifically, I want to reiterate what Jean said, although she's gone now, and many others. Multiple treatment options that are value-based for society continue to be needed and warranted. However, just because a medication is covered on an insurance company or because there's a rebate or a coupon that is available doesn't mean that it's value-based for society. And so I think it's really important because this is a public health crisis. We're all paying in one way or another, rising insurance costs, rising premiums, or through more public payers. I think it's important to consider the total cost of drugs and not just say, oh, well, it's covered through a rebate or through a coupon or things like that. So those are my thoughts.
All right, thanks. Austin?
I'm not sure I can remember another condition that this panel's examined that has so many large spillovers from the patient to broader society. This condition has dramatic effects on families, businesses, and communities, and we all know that. And I think that's reflected very well in the introductory language of this report, where it doesn't come through, and I understand why, just because we don't have the data and it's difficult. It doesn't come through in the modeling, and so I think maybe bring that back in the concluding discussion that there's when we're talking about treatments of patients, we're not just treating patients. We're trying to treat whole communities because that's the only way this country is going to recover from the epidemic.
All right, thank you very much. Martha?
So thank you all for this very informative day. I guess I've been thinking a bit about the notion of precision medicine, which is gaining so much currency, which is often framed in terms of sort of genetic and molecular basis, but it seems that precision medicine also has to do with behavioral choices and what people can do within lifestyles. So it seems to me for this huge public health problem, we need to be sensitive to the ability of different patients to pursue different ways that work for them in rehabilitating or preventing relapse. At the same time, the sort of notion of treatments crowding out other treatments is a tremendously huge problem. And I think about back to the days when AIDS and HIV were coming forward and people were, who had other kinds of illnesses became enraged by either, depending on which side you were on the expense of the drugs and what community health centers couldn't afford because they were mandated to do particular kinds of treatment. So I think this notion of value is, sort of central to solving a public health crisis.
All right, thank you very much. Albert?
So there are two things that somewhat resonated with me. One is access, and I'm really concerned about those states that don't have Medicaid expansion, and what is that going to look like, for this particular population. The other is, and I'm echoing a lot of the other sentiment here, about more options, because this is very complex. I mean, not everyone reacts to treatment the same way. So to have that menu of more options available, I think will, definitely be an asset. And, as Austin was saying, this impacts not only the patient, but families in the community itself. So these are just some things to consider.
Thank you very much. Ed?
I was struck by how consistent we were as a CEPAC in our voting. I think we agreed with each other more than we have in any other meeting that I could think of. And the lack of a strong case for value, I think, didn't deter us from recognizing the need for access to the expensive drugs just so that we can fit the needs of the heterogeneous population.
So for me, the fact that keeps sticking in my head was in the report where it said that 30 million people live in a county where there's not a single prescriber. So all of the options that we were coming up with, so simultaneously with working with creating more options and value-based options, I think we really need to pay attention to when we have those great new treatments, how can we ensure that people can get them in their own communities? So I worry a lot about that and the policy barriers that are in place to making sure we're fully utilizing our workforce to provide those options in the community. And the second piece of access that I think we also need to consider is the social stigma, to raise your hand to ask for help, and for having families being able to support decisions to bring this out to the public. So in that, maybe Austin makes a good point about how we need to look at this as a community crisis and engage the broader community to create that safe space. So lots of work ahead, but it's really been a great day with all of you, and I appreciate your input.
Thank you. Steve?
Thanks to all the panelists. It was a great day. One thing that struck me was sort of the lack of really tangible outcome measures in the trials, and I was sort of underwhelmed by the data that we were looking at. I think some of that was through the selection of the studies that were part of the process. If we had included more epidemiologic or outcome data, we may have seen impacts on mortality or other endpoints that may have been a little bit more compelling to the story. So I'll be doing some of that homework on my own. But thanks for the great discussion, everybody.
Great, thank you. Claudia?
I'll echo that sentiment. But I was struck by, despite the really insufficient evidence-based information we have about differences between therapies, I think that we really do highlight, as a couple of other speakers have just mentioned, that this does have to be, speaking as a clinician, a patient-centered choice for individualizing therapy. And we do have options here, and that we shouldn't constrain those options, at least not as much as possible. We have to define who is best for what kind of therapy. It has to be individualized. The other aspect that I was concerned about is that we do have very limited long-term data, so we really don't know. We have data on 12 weeks of therapy, 6 months of therapy, but this is a chronic disease, and we just don't have the data on the results of long-term treatment outcomes with these various modalities.
Great, thank you. Julie?
Thank you. So I will just echo the need to, again, preserve access to the multiple treatment options out there, because it is such a complex condition with such complex subpopulations that range from the incarcerated to your fishermen that need to go out on the boats. And so it's the importance of employing multiple policy options to preserve access.
Thank you. Rob?
Well, as chair, I get to thank everyone for being so succinct and focused in their comments today and saving me from embarrassment. The evidence issue has been raised by a number of people, and the evidence puzzle, I think, is an appropriate way to put it. The one thing that I would say there is, obviously we need more evidence, but there's something that the manufacturers, I think, could really address here from the standpoint of understanding value, and panels like us and payers to understand value, and that is to design studies, because most of the data that we have to evaluate are coming from you. Design studies that help us to see the value as opposed to non-inferiority trials, which again, it's wonderful from an FDA perspective perhaps, but not very good in assessing value. And the same kinds of issues we see in other conditions where we're looking at p-values to try to assess why a drug should be preferred when it costs 10 times as much. We're saying the same kinds of things here with the strategies that are being used to bring these products to market. So I think that would be really helpful.
All right, thanks. So just a few closing thoughts for me. One is actually to praise, I could praise many things, but kind of piggybacking off of what you said, I would like to praise the companies that compared their new formulation or new drug to Suboxone, because it's that kind of comparison that helps clinicians and patients and policymakers do a better job of understanding value. It's obviously ideal if you're shooting for the same general target in terms of the types of patients who might take the drug, to frame the eligibility criteria and the outcome measures a little bit more similarly so that we could compare apples to apples. Sometimes, though, you're looking for a different market, a different clinical need, so that's fine. But I really do want to highlight, because sometimes we don't have comparison to an active comparator, that at least that was a very positive aspect of enabling us to do some of the work we discussed today. The other thing I'd like to say is, as part of this old process, we all look back at ICER's report from 4 years ago, which was based on, again, the discussion among the CEPAC and a set of policymakers. And it's both, to read it again 4 years later is both, makes me feel both optimistic and incredibly kind of sad, because a lot of the recommendations you can feel we've barely made headway on in this country. Whereas others, I think we've actually kind of seen some change. Buprenorphine was incredibly tightly managed by many, many payers in those days, with having to have clean urine tests for a long time to get in or stay on it, to have documented ongoing behavioral counseling as part of the extension of treatment. We talked, though, about methadone, and we didn't talk about methadone today, but I'm not sure there's been a huge amount of work to increase access to methadone and to make that less stigmatized. So we will revisit this list of 10 policy recommendations that came out of a 4-year-ago meeting and try to put those into context. But I also think that we've seen today a different phase of the evolution of innovation where we are seeing really important kind of advances in providing, if not new mechanisms of action, different formulations, different mechanisms of delivery that may have a really important clinical benefit for certain patients. You've heard me on my soapbox out there, but I'll just say it again. I still think that there is a deep need by all parties in our society to figure out how to exercise a mutual responsibility around cost and access so that we can figure out how to get this to the patients and families who will benefit. We all bear that burden, and there's no perfect solution, but I express my optimism again that having these kinds of meetings and trying to talk about these difficult issues in public with evidence as our best guide will never make it completely easy, but it's going to make it at least a more, a kind of more inclusive process, I hope, going forward. So thank you for all of your engagement. Thank you to the work of the ICER research team. You guys were great. To our clinical experts who helped us all the way through, and the patients with whom we spoke as well, and the manufacturers for your collaborative engagement with us. It doesn't always mean that we agreed even to disagree sometimes, but we couldn't do this work without the insights that you give us, even if we seem to have hard heads sometimes. We have our own judgments and our own independent kind of thoughts that we obviously have to follow as our North Star. So thank you for those of you in the audience. The final report and other materials will be posted early in December, and that doesn't stop the work in any way on all of this, but I think, again, that this will be an important signpost, and we hope it will help policymakers and others in the future. Thank you very much.